All right, so today we're going to be speaking about the role of sedative agents in critical care. Again, my name is Verona. I'm one of the PGY1 pharmacy residents at Stony Brook University Hospital. I would like to thank Caesar for authenticating and providing the material in this presentation. And for pharmacists, today we're going to recognize indications for sedative use, compare and contrast the pharmacodynamics and kinetics of different agents, identify dosing and titration strategies for different agents, discuss the subjective and objective monitoring techniques, as well as describe some of the concerns that can arise from sedative use. For technicians, we're going to identify agents classified as sedatives, recognize indications for use, I indicate the differences between commonly used sedative agents in critical care, and name the different complications from prolonged sedative use. All right, we're going to start off by looking at Mrs. FM and following her course throughout this presentation. So she's a 54-year-old female who's admitted to the intensive care unit in acute respiratory distress syndrome, or ARDS, secondary to a viral infection. She requires invasive ventilation measures and then is subsequently intubated and placed on mechanical ventilation. Her past medical history includes hypertension, hyperlipidemia, and diabetes mellitus. And here are her lab values. We see that she has a little bit of an anion metabolic acidosis, some transaminitis, and high triglycerides. Her hematology is normal, and her vital signs, we see that she has a fever, she has low blood pressure, and a high heart rate. High respiratory rate, she's not oxygenating well, and then her venous blood gas shows us that she is hypercapnic and is low on oxygenation. All right. Okay, so over 5 million patients are admitted annually to the intensive care unit in the United States for intensive or invasive monitoring. And as you see here, there are a multitude of diagnoses on this list, but the medications and supportive care that's offered for many of these conditions often overlap. In the intensive care unit, this can range from close monitoring and exams to support of the airway, breathing, or circulation. The two main requirements that would require a patient's level of care to be upgraded to the ICU are either vasopressor requirements to stabilize systemic circulation, or mechanical ventilation to support the airway and maintain adequate oxygenation. And along with ICU level care might also come the need for either intermittent or continuous sedation due to a specific indication. Critically ill patients who require an ICU admission are subject to a high number of interventions that can lead to a significant amount of pain and stress. So some of these examples are mechanical ventilation, the process of going through endotracheal intubation, and vascular access through a central venous or arterial catheterization. These interventions can often lead to excessive pain and agitation, and patient outcomes may range from discomfort to increased mortality if this is not addressed. So the goal of sedation is to be able to provide patient comfort in a personalized way. What is essential for this patient? What conditions does this patient have that the side effect profile of a sedative might exacerbate? And does this patient require sedation to be continuous or intermittent? Not every patient in the ICU is indicated for continuous sedation, and more specifically, not every mechanically ventilated patient requires continuous sedation, but some conditions do warrant the need for continuous sedation, which is going to be our focus of the presentation today. And before we discuss the different agents, I want to understand the two main sources of distress that many clinicians are going to make an effort to address in the ICU. So more than half of ICU survivors report severe and uncontrolled pain as their most traumatic memory during their ICU stay. Uncontrolled pain is often associated with long-term effects such as chronic pain and lower health-related quality of life. This pain is due to a number of reasons. So vascular access, like we spoke about earlier, so insertion of an arterial line or central access, tissue injury because of trauma or a decubitus ulcer formation, general ICU care, repositioning the patient, nasogastric tube insertions, wound care, and endotracheal intubation. So the process of endotracheal intubation, along with the tube being in the patient's throat in a very uncomfortable position, and then general care that requires suctioning of the tube. These are all very painful procedures. For this reason, there's an approach to sedation that's referred to as analogosedation, which is an analgesia-based sedation strategy that targets pain and discomfort with analgesics prior to introducing a second and more traditional sedative. So agitation can be present in many ICU patients and can result in poor outcomes and even an increase in mortality. So it occurs at a similar rate at night and during the day, which can be because of sundowning or disruptances in the sleep-wake cycle. So some sources are untreated pain, which we discussed in the previous slide, vent asynchrony, because the patient and the vent are trying to breathe in different ways, anxiety, because the patient is unable to anticipate what will happen next, physical restraints, such as that would stop the patient from even itching an itch that they have, excessive noise that they're unable to control that can actually also lead to sleep deprivation, and then illness-related factors such as fevers, hypoxia, dehydration, withdrawal. And based on the etiology of the patient's agitation, the clinicians are going to be able to select a more appropriate agents to treat it. So pain and agitation are two of the main factors that make a stay in the ICU traumatic for patients and influence negative outcomes if they're not addressed appropriately. Okay, and as previously mentioned, continuous sedation is not indicated for all mechanically ventilated patients in the ICU. It's actually indicated for a small subset of patients in which treatment with continuous sedation will cause more benefit than harm. So exposing patients to continuous sedation is actually a predisposition to increased morbidity following discharge from the hospital. And during this presentation, we will discuss why. So critically ill patients are also more prone to increased adverse events due to reduced drug clearance secondary to possible organ failure, release of inflammatory mediators caused by trauma, and baseline hemodynamic instability, which can lead to unpredictable response with continuous administration. Okay, so continuous sedation is only medically necessary for a small subset of patients, and these are the patients it's indicated for. So patients who are dysynchronous with the vent. It's actually also referred to as bucking the vent. And these patients are over-breathing the vent, and there's an excessive respiratory effort, an increased work of breathing, and that means they're still retaining too much carbon dioxide. So what the team does is they get an arterial blood gas, and they see that the patient is in fact retaining too much carbon dioxide. So the patients are then put on continuous sedation to cause a sort of respiratory depression and cause them to be synchronous with the vent. Patients who are on continuous neuromuscular blockade. So these agents are able to paralyze the diaphragm, and these patients need to be sedated because they're paralyzed, and we don't want them to remember that they were paralyzed because it is such a traumatic experience. Patients who are in delirium tremens secondary to alcohol withdrawal. So because of prolonged alcohol use upregulates glutamate. Once you take away that GABA, then you have an excess of glutamate and you get seizures, tremors, hyperexcitability. So these patients need to be sedated in order to be titrated off their high requirements of GABA and to eliminate any seizure activity and hyperexcitability of the excess glutamate. Refractory status epilepticus, we have to sedate these patients in order to halt the seizure activity, and often with very high doses of sedation. So targeted temperature management, it's actually also referred to as therapeutic hypothermia, and it's induced in patients who suffer a cardiac arrest after the return of spontaneous circulation, or ROSC, in order to reduce anoxic ischemic brain injury. And these patients have to be adequately sedated during targeted temperature management, or TTM, in order to prevent shivering and allow for adequate ventilation. And then last, we have increased intracranial pressure. So increased intracranial pressure can be caused by a mass, a brain bleed, or swelling of the brain. And a decrease in the cerebral volume is actually going to cause a reduction of the intracranial volume and then therefore intracranial pressure. So sedation and analgesia reduce the pain and agitation that can actually cause arterial hypertension and then an increase in the intracranial pressure. Okay, so we just have a quick knowledge check here. Continuous sedation is indicated for all mechanically ventilated patients in the intensive care unit. True or false? False. That is correct. Thank you, Maura. Yes. All right. So in this section, we're going to be discussing the commonly used agents for continuous sedation. All right. Common properties that all sedatives have are these properties right here. So not all sedatives have all of these properties, which can also influence the selected agent based on the indication we're using it for. So analgesic, anxiolytic, it means it's able to relieve distress, anxiety, and agitation due to stress. Analgesic, it's able to relieve pain, which is a big cause of distress in critically ill patients, as we mentioned before. Anticonvulsant, it's a class of medications that's able to halt seizure activity. And amnestic means it's able to cause a temporary loss of memory, which can be useful for procedures, surgeries, and any invasive interventions, and especially when a patient is on a paralytic. Hypnotic, it doesn't mean to hypnotize, it means that it's able to induce sleep, which is a common property that all sedatives have. And then respiratory depression. Typically, this is not a desirable property that we want, but in this specific patient subset, maintained on mechanical ventilation, typically the team would prefer to control how a patient is breathing if they're on a ventilator. So this is an important property that we want to have too. Okay. So what is our ideal sedative before we go into the sedatives? And I just want the audience to keep this in mind as we go forward with our presentation. An ideal sedative is free of serious side effects. It's not associated with significant drug interactions. It's not accumulated with repetitive or continuous dosing, even in the presence of organ dysfunction. It's easy to administer, it has a quick and predictable onset and offset of action, and it's inexpensive. But this, of course, does not exist. There is no sedative analgesic agent that's sufficiently superior to any other agent to warrant its use in all clinical situations. Please keep this in mind as we go through the common continuous agents that we actually see in the ICU. So these are the common classes of medications that we are able to administer as continuous infusions. So we have opioid analgesics, anesthetic sedatives, central alpha-2 agonists, and benzodiazepines. So the analgesia first strategy is supported by a high frequency of pain and discomfort that patients experience in the ICU that we touched upon before. The Society of Critical Care Medicine recommends analogous sedation be used first in mechanically ventilated patients because they looked at 4 unblinded studies that included about 630 medical and surgical ICU patients, and they found that in these patients, the analogous sedation method when used first was associated with longer ventilation-free time, a shorter ICU length of stay, but these patients will also require additional sedation with traditional sedatives. And it's hypothesized that the analogous sedation method may limit potential adverse effects from more traditional agents, but that has not been proven yet in the literature. All right, so opioid analgesics are the most commonly used agents for continuous sedation, and there is an emphasis on administration for management of agitation secondary to pain in these critically ill patients. So all of these agents are equally effective when administered in doses equivalent in potency, and they have properties for hypnosis and analgesia, as well as respiratory depression, which we're able to use to our advantage in these mechanically ventilated patients to control their oxygenation. And common opioids that we can use continuously for the purpose of sedation are fentanyl, morphine, and hydromorphone. So opioids actually exert their effect by binding to the opioid receptors mu, kappa, and delta, and they're abundantly present in both the periphery and in the central nervous system. And by binding to the mu opioid receptor, the opioids are essentially causing a closing off of the calcium-gated voltage channels and then causing a decrease of release of excitatory neurotransmitters, which makes a neuron less likely to fire on action potential. So through this, they're able to inhibit pain transmission to the brain, and they primarily cause respiratory depression by altering the brain's responsiveness to carbon dioxide. And in turn, that actually impacts the brain's response, the brain's cognitive function. So essentially, they're able to induce sedation by causing a respiratory depression. Right, so here are the common agents. First off, we have fentanyl, and fentanyl's pharmacokinetic and pharmacodynamic profile and cost makes it an attractive analogous sedative. So it's a CYP3A4 substrate, which can actually interact with inhibitors such as the azole antifungals and cause an increase in the half-life and in potential adverse drug reactions. So once it's metabolized into its inactive metabolite, it's actually eliminated by the kidneys. It has a short half-life and a quick onset of action within 1 to 2 minutes of a bolus, and it's highly lipophilic and has a high volume of distribution, and it also maintains a 3-compartment model. So what that means is it's able to reach the blood, the brain, and the adipose tissue since it's very highly lipophilic. And this could actually be a problem since it's a continuous infusion and could lead to a prolonged and unpredictable clearance, because even once you shut off that continuous drip, the fentanyl is actually going to start redistributing from the adipose tissue back into the blood and might distribute back into the brain. So that's what makes its clearance unpredictable. Let's see. So it's a good choice for analgesia for most critically ill patients, but it's not the perfect agent because it's, like we said, metabolized by CYP3A4. Patients with hepatic impairment are actually at a much higher risk of accumulating the drug and experiencing adverse events from its administration. All right. So next we have morphine, and this isn't commonly seen as an agent for continuous sedation, and because there are so many drawbacks and concerns with this drug. So it's hepatically metabolized by glucuronidation into 2 active metabolites that are then actually eliminated by the kidneys and can accumulate with chronic use in patients with decreased renal function, which is very common in patients who are critically ill. And one of the active metabolites, morphine 3-glucuronide, doesn't have any analgesic activity but can induce seizures or agitation. Morphine is hydrophilic, which results in a slower onset of action than fentanyl, and it also is very poorly titratable because it has a longer half-life. Additionally, it can actually also cause a histamine release, and that can lead to a venodilation and bradycardia, so it really has a specific place in therapy that we're going to discuss. Next is hydromorphone, and hydromorphone is an analgesic option that can be used as an alternative to fentanyl. One advantage hydromorphone has is its non-CYP metabolism, which can be an advantage for patients with minimal hepatic dysfunction, since glucuronidation is less affected in early liver dysfunction than the CYP enzyme system is. So there's less accumulation in patients who don't have severe liver dysfunction. However, it does produce a inactive metabolite, hydromorphone 3-glucuronide, which is also eliminated by the kidneys. For patients with renal dysfunction, it can lead to accumulation of that toxic metabolite, which is also neurotoxic. So its onset of action is about 5 to 15 minutes. So it typically requires a bolus dose when initiating and titrating the infusion. And it's an option for opioid rotation in patients who are actually no longer responding to high doses of other opioids because of the incomplete cross tolerance between the opioids. All right, so here are the dosing titrations for each of the sedatives, and all of them do require loading doses, even though fentanyl does have a quick onset of action. These are not necessarily hard maxes. These are agents that you titrate, and the dosing and titration values aren't really well defined for analogous sedation, since the response is very patient and sedation goal specific. All right. So these agents are preferred for sedation, but there are some concerns that we have for continued use. So number one would be tachyphylaxis, and that's actually also commonly referred to as tolerance. So whenever a drug is administered continuously or repeatedly, there's a gradual loss of that response that occurs. So this is a common phenomenon that we see with opioids, and it can lead to less response with higher doses of these agents. And then redistribution is also a concern. And I spoke a little bit about it with fentanyl. So it's seen most commonly with fentanyl because it follows the 3-compartment model where it accumulates in the adipose tissue. And then after continuous sedation is turned off, it actually goes back into the bloodstream and can actually go back into the brain. So it causes a longer duration than we would like. And then withdrawals. So with longer than 7 days of therapy, the patients can actually suffer from withdrawals when the infusion is discontinued due to the extended exposure, and can actually exhibit symptoms that are opposite of the drug's effect. So we have to make sure that we monitor and keep this in mind. And reduced gastric motility. So this is very common with all opioids, and it does not diminish with time. It inhibits the motility in the colon. And when patients are on continuous opioid drips for an extended period, it can cause, it can interrupt enteral nutrition, and then patients might not be able to attain nutrition goals and can even develop ileus. So it's very important that we start these patients on a bowel regimen and make sure we do not induce this. All right, so to summarize what we discussed in this section, fentanyl is first line for analgesia in most critically ill patients. Hydromorphone is an alternative to fentanyl in patients with hepatic impairment and tolerance issues. And morphine really is used for air hunger and typically reserved for terminal weaning in the ICU to keep patients comfortable. Okay, so the class role is first-line treatment for non-neuropathic pain in mechanically ventilated ICU patients. So quick knowledge check. Which of the following medications would be appropriate opioid analgesics to start for an opioid-naive patient on continuous sedation? That is correct, Maura. It is D. All of these would be appropriate to start for continuous sedation. Okay, so the next class of medications are our anesthetic sedatives, and they're a class that's able to cause a loss of physical sensation with or without the loss of consciousness, depending on the agent. So there are 2 medications in this class that have different mechanisms of action, and they are propofol and ketamine. So propofol is the most commonly administered traditional sedative in the ICU, but lately there's actually been more use of ketamine, and many clinicians are unfamiliar with its use since few studies have described the use of it as a continuous infusion. All right. So the mechanism of action of propofol is uncertain. It's hypothesized to activate central GABA receptors with some modulation of the hypothalamic sleep pathways, and it also likely involves glycine, muscarinic, and nicotinic receptors. And the stimulation of these receptors is able to produce sedative, hypnotic, anxiolytic, amnestic, and anticonvulsant properties, but however, it does not produce any analgesia. Ketamine is an NMDA receptor antagonist, and the mechanism by which this works is it binds to a non-competitive site on a sensory nerve cell that in turn doesn't allow for glutamate, an excited neurotransmitter, to be able to bind to the cell, and it causes a dissociative effect, which I'm going to define in a couple of slides. But in addition to NMDA antagonism, it has agonistic effects on the mu and kappa receptors, and the action on these receptors is able to produce a dissociative, hypnotic, amnestic, analgesic effect. So it's actually also classified in the class of analgosedation agents. All right. So propofol is useful during the intubation and continuous sedation because it's highly lipophilic and it facilitates passage into the blood-brain barrier, and that actually leads to a very quick onset of action of less than 1 minute. So this is actually very useful when patients require frequent neurological examinations, and a sedative that's able to quickly sedate them and quickly wean off to make sure that they're awake, because it wears off in about 5 to 10 minutes. The typical dosing here is about 5 to 50 micrograms per kg per minute with a max of 80 micrograms per kg per minute. We can't administer this as a bolus since it's associated with dose and rate dependent hypotension. The metabolism is through CYP2B6 and it's also extrahepatic. The half-life is about 3 to 12 hours, but the extended use of propofol over 48 hours alters the half-life to be 24 to 30 hours. So because propofol also follows a 3-compartment model, it's also able to spread into the blood, the central nervous system, and adipose tissue, and it can accumulate in adipose tissue and slowly redistribute, just like fentanyl, during prolonged infusions that can increase its half-life. So propofol is formulated as 10% lipid emulsion that contains aglectin and soybean oil, so it's contraindicated in patients with allergies to these two components. The bottles and tubing have to be discarded every 12 hours to reduce the risk of contamination. And the amount of propofol being infused has to be considered when calculating a patient's nutritional intake, since it provides 1.1 kilocalorie per ml. So for example, propofol dosed at 50 micrograms per kg per minute in a patient that weighs about 70 kilograms would provide about 500 calories of lipids per day. All right, and propofol drug concerns. So hypertriglyceridemia, it's because propofol adds considerable calories that can actually lead to hypertriglyceridemia in about 20% of the patients. And pancreatitis has also been described secondary to this, but there have been reports of pancreatitis even without the presence of hypertriglyceridemia, which suggests that other mechanisms are at play here. Triglycerides should be monitored regularly while on a continuous infusion, and infusions should be discontinued when the concentrations exceed 500 milligrams per deciliter. Hypotension occurs in about 25% of ICU patients who receive propofol for sedation, and it's seen in patients who have a low intravascular volume or systemic vascular resistance, which is a very high number of patients in the ICU, and will likely lead to vasopressor requirements. And as previously mentioned, these bolus doses are not recommended due to the risk of hypotension. Cardiac arrhythmias, they're uncommon. They're reported in about 1 to 3% of patients, and the most commonly seen is bradycardia, and that's hypothesized to be due to propofol's effect of decreasing the cardiac beta-adrenergic responsiveness that can lead to cardiac depressive effects. And propofol-related infusion syndrome, or PRIS. So this is a rare complication in about less than 1% of the patients, but it has a high mortality rate of 30 to 60%. So it's associated with administration of doses greater than 80 micrograms per kg per minute. And the mechanism behind it is unknown, but it's theorized to be due to alterations in liver metabolism of the lipid emulsion. And the clinical features of PRIS, it usually presents with metabolic acidosis, acute renal failure, rhabdomyolysis, transaminitis, and hypotension and bradycardia, and sometimes hyperkalemia and hypertriglyceridemia. All right, so ketamine. Ketamine is classified as a dissociative anesthetic. So that means it's able to distort a person's perception of sight and sound. And that produces a feeling of detachment or dissociation from the environment and often from the self. It's very different from propofol which makes the patient completely lose consciousness, whereas ketamine does not. So it's not commonly used as continuous sedation in the ICU due to the fact that there aren't many studies describing its use as a continuous infusion. So clinicians are often really unfamiliar with its use, and that's why it's reserved for patients who do not respond to traditional continuous sedatives. It's being used to manage alcohol withdrawals because of the NDMA receptor antagonism. that works to antagonize glutamate. And it plays a big role in, let's see, okay, so, sorry, excuse me. So this dosing is not concrete, the 0.04 to 2.5 milligrams per kg per hour. Because it's not well defined in the literature. There actually have even been reports of going up to 10 milligrams per kg per hour, but the safety of that is unknown. And it's metabolized by the liver and has a weakly active metabolite, norketamine, that's cleared by the kidneys, and it's lipophilic, so its onset of action is about 1 minute once the bolus dose is administered. All right, so the concerns. Hyperadrenergic state. Since ketamine is able to stimulate the sympathetic nervous system, it's able to cause less cardiovascular and respiratory depression, and causes high levels of norepinephrine and epinephrine, which can be good for the subset of patients who are in shock or hypotensive, but not so good for the patients who are normotensive. So secondary to this hyperadrenergic state, the elevations in heart rate might cause an increased demand of oxygen in the heart muscles. And if a patient has any underlying coronary ischemia, the increase in rate can actually exacerbate an ischemic event. All right, emergence phenomenon. So emergence phenomenon is one of the big adverse events that worries clinicians with ketamine use. It's been observed in about 50% of patients treated with ketamine, and it's characterized by symptoms that are similar to schizophrenia, where patients experience euphoria, vivid dreams, hallucinations, irrational behavior. And the state of dissociation has actually been hypothesized to correlate with ketamine blood levels and glutamate release. And there's even been some data that mentions that prior treatment with a benzodiazepine can decrease this phenomena, but the data is not concrete in the literature. All right, an increase in ICP. Some earlier data with ketamine use suggest it can increase intracranial pressure, but recent studies have disproved this, but still, until there's robust data, this agent wouldn't be appropriate to use in patients who have high intracranial pressure. And then psychiatric disturbances. So the disturbances of emergence phenomena are usually short-lived, but there's a fear that ketamine can cause a decompensation of psychiatric illnesses in patients who have these underlying psychiatric conditions. Okay, so just to summarize what we spoke about today, so propofol is first line for sedation because it has many useful properties, such as actually also decreases intracranial pressure, and there's some data showing that it can aid in controlling intractable seizures and can reduce shivering during the rewarming phase of targeted temperature management following a cardiac arrest. And ketamine is reserved for patients who are unresponsive to traditional sedative agents because of the lack of familiarity, like we spoke about, and it can actually be useful in patients who are in shock or hemodynamically unstable, and may be useful in alcohol withdrawals because it can be used to reduce the doses of opioids. All right, so next agent we're going to talk about is dexmedetomidine. So it is the only continuous sedative agent in the central alpha-2 agonist class. It reduces sympathetic outflow by blocking norepinephrine release, and this produces levels of sedation without respiratory depression. So it's about 2,000 times more selective for alpha-2 than alpha-1. So we see less hypotension and bradycardia effects with its administration. Dexmedetomidine offers many advantages. It's used as an adjunctive agent for patients who are undergoing alcohol withdrawal for its calming and symptom management effect, but dexmedetomidine itself is unable to treat the causes of withdrawal. So it's able to improve REM sleep, which is more restful, but clinical benefit still seems unclear. Dexmedetomidine is administered as a continuous infusion at 0.2 to 1.5 micrograms per kg per hour. It should not be administered as a bolus because of the risk of hypotension, since it still carries alpha-1 agonist properties and it's readily titratable. But its duration can be prolonged in patients who are elderly and have hepatic impairment. So the next study that looks at the efficacy or viability of dexmedetomidine as a sedative in the ICU are the PRODEX and MIDEX trials. And the clinical question that the study wanted to answer was, is dexmedetomidine non-inferior to more traditional sedatives, midazolam and propofol, in maintaining mild to moderate sedation levels? So these are two parallel multi-center randomized double-control trials in the mechanically ventilated patients in the ICU. And they were randomized 1-to-1 and dexmedetomidine and propofol and dexmedetomidine and midazolam. And the primary endpoint that was assessed was the proportion of time in target sedation range without rescue therapy and the duration of mechanical ventilation. And what the study found was that compared to propofol, midazolam, dexmedetomidine was non-inferior in time to target sedation, and was non-inferior compared to propofol in shortening the time on mechanical ventilation. But when compared to midazolam, it was actually able to decrease the duration of mechanical ventilation, but had no effect on length of stay in the ICU. So the authors were able to conclude that dexmedetomidine was non-inferior to propofol and midazolam in maintaining target sedation levels, but the results of this study can only be applied to patients who are receiving light or moderate sedation, not deep sedation. All right, and concerns that we have with dexmedetomidine: because of the alpha agonism, we're able to see some hypotension and bradycardia with continuous administration, and it should be avoided in patients who are experiencing acute decompensated heart failure or heart block. There have been some reports that dexmedetomidine is able to induce a fever that's higher than 40 degrees Celsius in some patients, but these reports are rare, and clinicians have to rule out other causes of fever such as infection or inflammation before they point to dexmedetomidine as a potential cause of that fever. And then variability in its effects. So it's very different from patient to patient. It's hypothesized to have some analgesic properties, but they're unable to be quantified because of the variability in the patients. And even when administered as a continuous sedative, it varies from patient to patient, the level of sedation that it's able to warrant. Okay, so to summarize dexmedetomidines role in therapy, it could be used as an adjunct to opioids to help decrease the dose if need be. It's used as an adjunct to benzodiazepines and propofol when used for alcohol withdrawal. And just to be clear, it's used for its calming and symptom management effect, but it does not actually treat the underlying cause of the withdrawal. And it's a bridge to extubation while you're tapering off longer acting sedatives. So unlike propofol, benzodiazepines, and opioids, dexmedetomidine does not suppress the respiratory drive, which is why it's a great agent to use to keep patients calm while you're extubating them. Okay, quick knowledge check. All right, we're gonna go back to Mrs. MF. She's deeply sedated and on fentanyl, dexmedetomidine, and propofol. And now we're checking her triglycerides, and we notice that they are 600. So which of these agents are most likely to cause this lab abnormality? Yes, that is correct, Maura. It is propofol. Okay, oops. All right, so the next and last class of drugs are benzodiazepines, and the two agents available for continuous sedation are midazolam and lorazepam. Just as with opioids, they're equally efficacious when administered at doses that are equivalent in their potency, but they differ in their kinetic profile in that that can influence the agent selection. So the major drawback with benzodiazepines is that they're associated with longer mechanical ventilation when compared to dexmedetomidine and propofol, just as we saw in the PRODEX and MIDEX trials. And some studies also show that they have an increased length of stay in the ICU. Benzodiazepines mainly bind to GABA receptors and modulate that specific neurotransmitter. At lower doses, they have an anxiolytic effect by inhibiting the activation of the amygdala, and At higher doses, they're able to promote sleep by binding to a region in the hypothalamus that causes sedation. So they're able to produce anxiolytic, amnestic, hypnotic, respiratory depression, especially when used concomitantly with an opioid, anticonvulsant effect, but no analgesia. All right. The differences between these two agents are really similar to the differences between hydromorphone and fentanyl. So lorazepam is metabolized through glucuronidation and renally eliminated. So it can accumulate in the tissues in the setting of renal impairment. It's less lipophilic than midazolam, so that results in a slower onset of action and slower exit from the central nervous system. So the major drawback of lorazepam is its insolubility. So injectable lorazepam is diluted in a propylene glycol solvent, and that propylene glycol can actually cause toxicity, and it can occur with lorazepam infusions if you use it for more than 48 hours at high doses of about 6 to 8 milligrams per hour. So the way to monitor for propylene glycol toxicity is through monitoring of the osmolar gap. And how we do that is we take the measured osmolality and we subtract the calculated osmolality. And then if we have an osmolar gap of 10 to 12 milliosmoles per liter, that means that this patient may be experiencing toxicity. And if they also have metabolic acidosis, any unexplained new onset renal or respiratory failure, lorazepam should be discontinued. And it's usually reserved for patients who are experiencing liver failure but still require a benzodiazepine. All right, and midazolam is the most commonly used benzodiazepine. It's a CYP3A4 substrate, so it also carries a risk for drug-drug interactions, and it's highly lipophilic, so it can accumulate in the adipose tissue. It has a short duration if it's administered for less than 48 hours, but there's a buildup in the patients who have liver or renal impairment and are elderly. And the risk of oversedation is due to that delayed response and accumulation in the adipose tissue because it's highly lipophilic, just like we saw with fentanyl. And the redistribution also works very similar to fentanyl. What's interesting about this is it actually works synergistically with propofol because it's a CYP-mediated drug-drug interaction that leads to increase midazolam concentrations and enhanced GABA agonism. And here are the dosing for both agents. These are not concrete, and typically we try not to go over 10 milligrams of midazolam because of the high risk of side effects that we see. And the class concerns of this class, there are a lot of the same concerns that we had with opioids. Tachyphylaxis with continuous sedation can cause the gradual loss of response, redistribution, especially with midazolam because it's lipophilic. The withdrawal, especially if it's used longer than 14 days, and delirium, which is a major concern with benzodiazepines, and it's described in the literature. So we're going to go over a quick study, the SETCOM study. The major clinical question that the study was hoping to answer is, what is the efficacy and safety of prolonged sedation with dexmedetomidine when compared to midazolam? So it's a multi-center, double-blind, parallel group randomized control trial in mechanically ventilated patients in the ICU. It was randomized 2-to-1 in favor of dexmedetomidine, and the primary outcome that we were looking at was percentage of time within the target RASS range of -2 to +1. And the secondary outcomes that were assessed were delirium, mean delirium-free days, and median time to extubation. And what the study found was that there was no difference between the agents in the primary outcome, but the prevalence of delirium was actually higher in the midazolam group at 76.6%. Versus 54% in the patients who were treated with dexmedetomidine. And there were longer mean delirium days in the patients who were treated with midazolam versus dexmedetomidine, and a shorter time to extubation in patients who were treated with dexmedetomidine versus midazolam. So the authors concluded that there's no difference between dexmedetomidine and midazolam in achieving the time within the targeted sedation level, but dexmedetomidine resulted in less time on the ventilator and less delirium than in patients who were treated with midazolam. And just to summarize quickly the class role in therapy, so benzodiazepines are first line in status epilepticus because of their anticonvulsant properties, in alcohol withdrawal and in benzodiazepine withdrawal because of GABA. They're able to induce deep sedation and amnesia when indicated. So for this reason, they're first line when using a paralytic agent, but ultimately they're not favored due to being a risk factor in developing delirium in ICU patients that we're going to be discussing in a small bit. Okay, quick knowledge check. MF's propofol is subsequently discontinued, and then the team wants to initiate midazolam. So MF also developed a candida glabrata in her sputum and urine, so they're treating her with voriconazole, which is a CYP3A4 inhibitor. Which adverse events do we expect to see while her sedation is maintained on these three agents? Yep. Okay, yep, the answer is all of the above. We expect to see all of the above. All right, so for monitoring. Okay, so throughout this presentation, we mentioned sedation goals, and titrating sedation to a goal sedation level has actually been shown to decrease time on mechanical ventilation, the ICU length of stay, and even rates of a tracheostomy. So our goal really is positive outcomes. So we have to appropriately dose sedation to not interfere with this clinical progress. The subjective scales, we have two validated subjective scales that are in use. So we have the RAS and the SAS tables, and yes, they are subjective in that they can vary from person to person, but they're validated to remove any bias between nurse to nurse measurements. And then we have our objective measurement, which is the bispectral index, or BIS, and that's used in patients who are concomitantly receiving a neuromuscular blocking agent because you are unable to measure these two, and we'll go over why. So the use of vital signs should be avoided because they can non-specifically fluctuate for many different reasons, and studies actually detailing their appropriateness are conflicting. All right, and so first off here, we have the SAS, or the Riker Sedation Agitation Scale. It is a scale of 1 to 7, with the higher numbers reflecting greater levels of agitation and lowers reflecting greater levels of sedation. Typically, our goal in the ICU would be a 4 or a 3 if they're sedated, and if we want to target for deep sedation, then our goal is 2. The biggest drawback is it doesn't actually examine the patient's ability to interact with their environment or their level of wakefulness by following simple commands. So that means you won't be able to see if the patient is a candidate for mobilization. And then the Richmond Agitation Sedation Scale, which is referred to as the SAS, this is the most commonly used sedation scale, has high reliability and validity in all types of patients, if they're ventilated or non-ventilated, sedated or non-sedated. It ranges from a -5 to a 4, with the higher numbers reflecting greater levels of agitation and lower numbers reflecting greater levels of sedation. So it's much more descriptive than the previous scale. And our goal typically is light sedation, which is a -2. But for some patients, if we want to aim for deeper sedation, we would aim for a -4. And then the last monitoring for sedation is the bispectral index, and this is considered more objective because it's able to interpret raw EEG signals and create a number for the level of consciousness versus just nurse or provider monitoring. So this actually assumes that cortical activity relates to the level of consciousness, and if we are going to assume that the patients are going to be deeply sedated, which they most likely will be, and they'll be unresponsible if we're using a bispectral index, then our goal would be a 0 to 40, which indicates that there's a deep hypnotic state. And that's typically reserved for patients who are on paralytics, therapeutic hypothermia, or we want to control their intracranial pressure. Okay, so what sedation goals are targeted during continuous sedation in the intensive care unit? There was a study that was done in the ICUs in Malaysia that looked at 259 patients that were sedated and mechanically ventilated for over 24 hours. And they looked at midazolam and propofol administered for sedation. And what they found was that patients who were kept on deeper levels of sedation had a longer time to extubation, greater hospital deaths, and a greater 180-day mortality. So the authors concluded that early deep sedation was independently associated with delayed extubation and a higher mortality regardless of the sedative choice. Okay, a second, there is also daily interruption of sedation. So this is for the purposes of assessing the need for continual sedation for mechanically ventilated patients. So it helps reduce complications that are related to prolonged mechanical ventilation. So typically what we do is we take the patients off station. So this is also referred to as a sedation vacation, and see if they're awake and following instructions, or if the patient is uncomfortable and agitated, and we see if they still require agitation. And this is done to assess the patient's neurological status and to help assist us in maintaining light levels of sedation. So there is no difference in outcomes between the daily interruption of sedation versus just maintaining the patients on light levels of sedation. And it's really unclear if the combination of the two could lead to additional benefits. It's been investigated in medical ICU patients, but has not been investigated in surgical, trauma, or neurosurgical patients. Okay, so even though we want to maintain these patients on light levels of sedation, there are some exceptions to this. So if patients are on a paralytic, we do not want them to remember any experience of being on a paralytic, so we make sure that they are maintained on deep sedation. If the patient is on therapeutic temperature management secondary to a cardiac arrest, they have to be adequately sedated to prevent shivering, and that allows for neurological recovery. If a patient has refractory seizures, we want to induce a therapeutic coma to halt the seizure activity. And the way we do that is we keep them on deep levels of sedation. And patients with increased plateau pressure. So what this means is we want to induce a respiratory depression for the patients who are not able to adequately exhale enough air out, and breathing in more air causes higher pressures in the lungs. So we want to make sure that we induce deeper levels of sedation and respiratory depression, so they don't have increased pressures and have negative outcomes for their lung function from that. All right, so one more quick knowledge check. MF now is also being placed on a rocuronium, a neuromuscular blocking agent. Which of these sedation tools do we use to monitor her level of sedation? That is correct, everyone. It is C, bispectral index scale. Okay, so overall concerns of sedation. So delirium is described as an acute mental disruption characterized by a disturbance in cognition or awareness. So essentially, these patients are a little bit delusional. They're unable to receive, process, store, or recall information. And this is seen a lot in post-ICU stays, and it's a result of severe illness, excess sedation, excessive noise, and sleep deprivation. And development of delirium is actually associated with up to a 3-fold increase in mortality and an increase in cognitive decline and a longer hospital stay. So there were 2 recent studies that found a longer duration of delirium was associated with worse activity of daily living scores and worse cognitive impairment scores at 3 and 12 months post-ICU discharge. And there are 3 different types of delirium. So we have hyperactive, which is the least common, and it's easily recognized, so it has a better prognosis because it could be treated. And then we have hypoactive delirium, and that's poorly recognized, and so it has a poor prognosis because often we don't know that we need to treat it. And then we have mixed, which is the most common, and it's poor prognosis because we're unable to point a finger on what we need to treat. So this is a reason why benzodiazepines are not typically preferred as sedative agents if we can avoid them or keep use to a minimum, because typically what we see in these patients who develop delirium is we have a hard time recognizing them because, and they have actually a higher chance of dying within a year because they're unable to care for themselves or they're depressed and their caregivers might not recognize it, and the cognitive function that they will be that they have after ICU discharge is very different from prior to their admission. So really all we can do is we can try to prevent it, and there's no evidence supporting prevention with antipsychotics. So haloperidol is the most commonly studied agent, and what we found was that it reduced the time agitated when we used it in these patients, and atypical antipsychotics may reduce their duration of delirium. The 4 agents that were studied in this population were risperidone, ziprasidone, olanzapine, and quetiapine. And another concern that we have with these patients who are on continuous sedation are withdrawals. So since they've been receiving very high doses of continuous sedation, they're at a higher risk for withdrawal as the tapering process begins, or even when the continuous sedation is just shut off. So it's more likely with opioids and benzodiazepines. So for continuous infusion of opioids of more than 7 days, and for a continuous infusion of benzodiazepines of more than 14 days. And it manifests with characteristics that are opposite of the drug's effect. The risk factors and incidence of withdrawal haven't really been well characterized in the literature, but what we do see is the use of longer acting agents that we give orally prior to turning off the continuous sedative, such as methadone or oral lorazepam, can assist in titrating the long-term infusions. And with that, I just want to say I'm done. If anybody has any questions, thank you guys for attending. And I just want to say this is very big for these patients who are in the ICU, that we practice more preventative medicine, because our goals before used to be that we just fix the patient and we discharge them. But for now, we want to focus more on fixing the patient and not breaking them at the same time. So it's very important that we are careful in the way we select agents and the way that we practice in the ICU to make sure that even after discharge, these patients are able to have a better quality of life. And with that, I am done. If anybody has any questions.